I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
I'm so honored to be joining you along with my co-ambassadors, Francesco Egro from the University of Pittsburgh and Ira Savetsky from NYU. I'm Nicole Phillips from the Harvard Plastic Surgery Program. We are fortunate today to have Dr. Bernard Lee as our guest moderator. Dr. Lee is professor of surgery at Harvard Medical School, chief of the Division of Plastic and Reconstructive Surgery at Beth Israel Deaconess Medical Center, and co-director of the Peter J. Sharp Program for Aesthetic and Reconstructive Breast Surgery at BIDMC. Dr. Lee, thank you for joining us.
Thank you, Nikki.
The article I wanted to discuss this month is a great follow-up to last month's Twitter Journal Club discussion on lower extremity reconstruction. This article is entitled Muscle versus Fasciocutaneous Free Flaps in Lower Extremity Traumatic Reconstruction, a Multicenter Outcomes Analysis by Cho et al. Dr. L. Scott Levin is the senior author. This is a large, retrospective, multi-center study that re-examines the much-debated topic of the use of muscle versus fasciocutaneous free flaps for the management of lower extremity injuries. As we all know, the ideal lower extremity reconstruction would be one that restores function and form, promotes bony union, recovers sensibility, and limits donor site morbidity. Historically, muscle-free flaps have been considered superior to fasciocutaneous flaps for the management of open, contaminated lower extremity wounds, a perspective still maintained by some orthopedic and plastic surgeons today. Recent clinical evidence from several single-center series has suggested that muscle and fasciocutaneous free flaps achieve similar rates of limb salvage and functional recovery. The current study aimed to confirm these findings and take this a step further by looking at the rate of secondary flap revisions, as well as the need for staged orthopedic procedures and the impact of flap choice on this process. As previously mentioned, this was a retrospective study looking at patients treated for traumatic lower extremity injuries at either Duke University Medical Center or the University of Pennsylvania Health System over a 17-year period, which was 1997 to 2013. 518 cases were included for analysis and broken down into two subgroups: acute traumatic injuries, defined as defects reconstructed within 30 days of the initial injury, and chronic traumatic sequelae. Only primary free flap reconstructions were included for analysis. 307 muscle and 211 fasciocutaneous free flaps were performed within the study group. The mean follow-up time was 4.2 plus or minus 9.1 years. Primary study outcomes included limb salvage, return to ambulation, the occurrence of intraoperative and or postoperative flap thrombosis, flap salvage and the setting of thrombosis, flap loss, and non-union requiring bone grafting and Castillo type 3B tibial fractures. The secondary study endpoint examined the rate of secondary flap procedures performed following primary reconstruction, including flap elevations for orthopedic procedures, secondary skin grafting, and aesthetic refinement procedures. Patient variables studied included sex, age, BMI, current or prior tobacco use, and the following comorbidities: hypertension, diabetes, coronary artery disease, and peripheral vascular disease. The defects were classified according to location, divided up as above the knee, ankle to knee, or below ankle. Other defect variables examined were the presence of Castillo grade 3B injury, hardware exposure, and the time interval from acute traumatic injury to flap reconstruction. Provider variables and operative variables were also included in the analysis. Several statistically significant differences were uncovered in relation to baseline characteristics. For instance, the providers were more likely to select one type of flap over another based upon wound location or size. Importantly, in the acute traumatic setting, defect hardware exposure and flap size were independently predictive of worse cumulative limb salvage, while Castillo grade 3B fractures were independently associated with lower cumulative rates of return to ambulation. When examining reconstructive outcomes independent of these baseline characteristics, however, no significant differences were found between muscle versus fasciocutaneous flaps in relation to any of the individually studied primary outcomes. Both muscle and fasciocutaneous free flaps achieved similar rates of limb salvage and return to function. This finding held true among patients in both the acute and chronic traumatic injury subgroups. With regard to the secondary outcomes examined, several differences were highlighted. Fasciocutaneous flaps were more commonly re-elevated for secondary orthopedic procedures in patients with Castillo 3B injuries or exposed defect hardware. Muscle flaps more commonly required secondary skin grafting procedures among the acute trauma subgroup. No differences were noted in the rates of secondary flap refinement between the two flap groups. This study is the largest published outcomes analysis to date of muscle versus fasciocutaneous free tissue transfer in lower extremity traumatic reconstruction. The authors concluded that muscle and fasciocutaneous free flaps are similarly effective in restoring lower extremity form and function after traumatic injury, with comparable rates of limb salvage, return to ambulation, flap success, flap salvage, and primary fracture healing. The authors then highlight what they consider to be the improved aesthetic outcomes attainable with fasciocutaneous free flaps, as well as the ease and safety of re-elevating these flaps for lower extremity reconstruction in which staged orthopedic surgeries are planned. By emphasizing these potentially positive features of fasciocutaneous free flaps and presenting evidence to support the efficacy of these flaps in the reconstruction of traumatic lower extremity injuries, the authors justify the shift in free flap selection, which they report has occurred within their own institutions over the past 2 decades, with the use of fasciocutaneous flaps rising from 25% in the period of 1997 to 2000 to 65% in the period 2009 to 2013, and up 73% at the institution of the senior author. There are some limitations to this study, but overall I believe it presents compelling evidence to support the use of fasciocutaneous free flaps in lower extremity reconstruction and adds to the growing body of literature which has supported the use of these flaps in a wider variety of settings. Dr. Lee, I'm curious to hear about your own personal experiences with and preferences for lower extremity reconstruction, and I'm wondering if this study or any other recent study has changed the way that you think about lower extremity injuries.
First of all, this is a very impressive study about lower extremity reconstruction, as the numbers that are presented in this paper are astronomical when it comes to lower extremity free flaps. Of course, in this paper, the shift from muscle to fasciocutaneous free flaps is probably the most important part in the conclusion as evidenced by the data. Dr. Levin, an expert in lower extremity reconstruction, has shifted, it seems like, from muscle to fasciocutaneous free flaps, and this reflects the change from muscle to perforator flaps, which is mirrored in my own practice. I think nowadays more and more we are pushed to do lower extremity reconstruction, and secondary revisions are often necessary. In a fasciocutaneous flap, this is often easier because of the skin-to-skin interface between a perforator fasciocutaneous flap to the native skin, compared to a muscle flap with skin graft to the native skin, which can often be difficult to elevate if secondary revision is required. This is one of the key findings within this paper, is that in a fasciocutaneous flap, a secondary revision can be performed at a higher rate. The other interesting fact that was found in this paper was that muscle flaps required more skin grafting. This intuitively makes sense. At the time of the muscle flap, free flap reconstruction, a skin graft is often required, but sometimes a skin graft is not done at the time of the primary free flap, in which case a secondary skin graft is necessary, and that makes sense when you look at the data. I think when you look at the large series, the question always arises about infections and as to whether or not a muscle flap would improve in terms of infectious complications compared to a fasciocutaneous flap, and that did not bear true in the study, along with other studies that we've recently seen in the literature. And so this study goes a long way in showing us that a fasciocutaneous flap in performing lower extremity reconstruction is safe and efficacious, and the shift from muscle to fasciocutaneous flap is justified.
Great. Thank you so much, Dr. Lee. Ira, do you have any questions for the group?
I thought this was an excellent study. We know lower extremity reconstruction is very challenging and requires true expertise. And what Dr. Lee said, Dr. Levin and his group at Penn are true experts in this field and have a tremendous amount of experience. And I applaud the authors for trying to answer this much debated topic as to which type of flap we should be using to reconstruct these difficult injuries. My question to you, Dr. Lee, is as it relates specifically to the heel. It's a particularly challenging area to reconstruct. It needs sufficient padding, but also good contour to fit comfortably into a shoe. Ideally, it would be sensate as well. What is your go-to flap for heel pad reconstruction?
So typically with heel reconstruction, I like a thin fasciocutaneous flap. So my go-to would be an ALT flap. Nowadays, we're starting to do more and more thinned flaps or super thin flaps, and that can be innervated at the same time. And so I like to have a nice molded construct on the heel, especially for weight bearing and ambulation.
Yeah, that makes a lot of sense. Francesco, what do you think about this paper?
I thought it was a phenomenal paper. I also commend the authors on a very huge series, literally astronomical numbers, and looking into a very important and relevant topic in reconstructive surgery. And it comes from true leaders in the field. I thought this paper provides great evidence that muscle and fasciocutaneous free flaps can achieve comparable rates of limb salvage and functional recovery, which is, it's very important. And the ability of re-elevating these fasciocutaneous flaps, if the needs arise, is certainly a major plus. And I wonder if in the future more surgeons will also take this approach. I also thought, looking at the numbers, that it was very interesting to see how frequently the authors have used the fasciocutaneous flaps in patients with exposed hardware. Also, one of the groups examined looked at chronic traumatic sequelae, which includes osteomyelitis. And Mathis advocated the use of muscle flaps in chronic osteomyelitis. And I wonder, Dr. Lee, could this paper be a game changer in how we manage chronic osteomyelitis?
Interesting question, Francesco. I think the way that we treat osteomyelitis is starting to shift. And we have seen this from data from this series, but also from large data series from Taiwan, that has shifted the concept that a muscle flap is necessary in the setting of osteomyelitis and infection. And this paper right here shows that they're equal in terms of a muscle versus a fasciocutaneous flap. So I think there is a significant shift that's been coming. And conceptually, it makes you wonder why muscle flaps are performed for lower extremity reconstruction at this point in time. The reality is that there are certain defects and sizes of defects where a large muscle flap may still be necessary, in which case a large latissimus flap may be a better option than a fasciocutaneous flap if, for example, you need to fill defects or the interstices of a three-dimensional construct. That might be easier to fill with a muscle than a fasciocutaneous flap. But I agree with you that this is starting to change the way that we think about reconstruction of the lower extremity, especially in the setting of infections.
Thank you. Thank you very much.
Well, I want to thank everyone for a really terrific discussion. I think we had a very lively live Twitter journal club last month about the topic of lower extremity reconstruction. This is certainly something that we are all still discussing and trying to figure out the best way to get the best results for our patients. But I think this was a really important addition to that discussion. I want to remind everyone listening to tune into the other two articles we'll be discussing on this month's podcasts, as well as to join us for what will be our first live journal club on Facebook in January. So please take a look out for that as well. I want to thank my co-ambassadors and a special thanks to Dr. Lee for joining us for this discussion.
Great. Thank you for having me.